Oncology at the University of Bordeaux, who's going to talk about the limits of resectability. Thank you.
Thank you, dear colleagues. Thank you to invite me and to give me the opportunity to share with you this overview of how to face very complex situations. We are dealing now with very advanced disease, unresectable liver mets, borderline or bilateral, and we will see what we can propose and the evolution of the concept with time. First of all, I fear that the word resectability is old-fashioned. I think that in the future, and maybe today, we have to use operability because, as you know, or as you will see, we are more and more using intraoperative ablation, and so we do both resection and ablation. Of course, surgery is today the best hopeful scenario for patients having advanced liver mets, but if you push the limits very far, if you push the limits, you will increase the number of liver mets, you will change R0 to R1 surgery, you will accept more and more extrahepatic disease, and finally, the overall survival will be quite the same than the chemo group. So probably there is a limit in wanting to overcome the limits. So we'll see the nature of the limits, and first of all, the patient limits, and how the surgeon have to manage a liver catheter, the liver function to preserve, the vascular technique, which is the main problem for the surgeon, and the oncological limits. And finally, we will see how we can save more healthy parenchyma, how we can kill more metastases, and also why we should have better formation, better education for surgeons in intraoperative use of ultrasounds. And finally, we will discuss which is the real benefit, the real endpoint for the patients. So first of all, I think we have to start such a talk by saying that mortality of the classical series, like Gilles told, is less than 2%. But if you see the literature, in some series pushing the limit, they accept more than 10% of mortality, which for me is unacceptable. I think we should stick to 2%. And we'll see also, like Gilles told, that morbidity is very, very important. You will see the series at the end of my talk saying the same, that it could divide by 2 the overall survival. So, like Jean-Pierre Girard told yesterday, primum non nocere for the radiotherapist, but also for the surgeon is very important. So, the surgeon have to deal with what the nature gives to him, and sometimes nature is not favorable to surgery. In this female patient, you see that you have a complete right dominant liver, quite no left liver, so it was impossible to make a right hepatectomy. The same case in a male patient, you see that there is quite no left liver. So in this case, there is a problem to manage sometimes surgery. Also, liver mets recur very often, and so after one hepatectomy, you have a limitation of what you can do on a strict surgical point of view. Dividing hepatic adhesions produce bleeding. You have the problem of homeostasis, which is going down. You have scarred glycine capsula, which make the ultrasound impossible to go through the parenchyma. And also the vein, you have a restriction of the catheter. So when you assess a patient in the MDT staff, you have to see the volume first. And the volume, as you know, if the patient didn't get any chemo, it's 25%, so remnant liver volume. But after chemo, it's more 40, sometimes 45%. So we have to take this into account. A French team from Lille has proposed a ratio between the remnant liver volume and the body weight, and no patient died when the ratio was more than 0.5%. And of course, you have to keep at least 2 segments, but contiguous segment, because for vascular reasons, not the 8 and the 2, contiguous segment. And also, very important, the vascular catheter. You need 1 portal pedicle for the inflow and 1 hepatic vein for the outflow. And it's classical to say that if you have, for example, the right portal pedicle invaded and the median and the left hepatic vein invaded, it's a contraindication. It's not resectable, but you will see at the end that it is operable. But for the surgeon, please avoid to cut the small direct hepatic vein coming from the segment 1 and going directly to the vena cava, just to mobilize the liver. It's very important. It's a catheter, a functional catheter, and we have to be very conservative with it. Oncological limits, of course, surgery has to be integrated in the MDT decision. You cannot, it was possible during the 80s to make the same surgery than today, but it had no sense at this time. So it's very important to be in phase with the medical approach. Second, the R0 rule. At the present time, we are not allowed to make suboptimal surgery, like, for example, for neuroendocrine tumors. We have to resect all the disease. And we will see that dealing with advanced disease, the surgeon is working in what I call a systemic perimeter of efficacy determined by the chemotherapy it was used. It means that with 5-FU, you are not able to make the same thing that with FOLFIRINOX regimen. Back to history, for example, a German series from the 90s, they say only solitary or very few unilateral liver mets might be positively influenced by surgery. Another series by the US, no patient operated on from more than 4 liver mets alive at 3 years with systemic chemo. So during more than 15 years, it was a no more than 3 mets rule, which was mandatory for every surgeon. And if you see this interesting paper by Kopetz joining the Mayo clinic series and the MD Anderson, you see that there is a linear progress parallel with introduction of new regimen of chemo and more hepatectomies. And in 2004, with the targeted therapies, you get a strong increment in the results. So clearly, surgery and chemotherapy have to go on a parallel way. It's impossible to have a distinction between them. This is a very interesting question when you push the limit. Which is adjuvant to which? When you deal with 3 or 6 liver mets, surgery is, of course, the main treatment, and chemo is adjuvant. But when you deal with 10, sometimes 15, 20 liver mets, isn't it chemo the main treatment and surgery the adjuvant? So there is probably a turning point in between. We don't know exactly where is this turning point. Probably it's not the same turning point for different patients, but it's very interesting when you discuss the strategy. Oncological limits, extrahepatic disease. It is used to say that when you have a small extrahepatic disease, like a small carcinomatosis, 1 or 2 lung mets, it's not a contraindication, of course. But you will see that it's a very bad prognostic factors, which also divide by 2 the overall survival. So you have to take it into account. The margin, as Gilles told you, the margin is very important. There are a lot of papers on the margin we have to take for liver mets, and we have to determine until which margin limits we should accept to go. As for the rectum, as we discussed yesterday, we have to separate, to distinguish between the margin without any topographical concern, which means a liver mets in the full parenchyma, where you can decide to take 1 centimeter or 1 millimeter margin, and the resection by necessity, which is a R1 surgery because you cannot do anything else, because the metastasis is sticked on the liver, the pedicle, the portal pedicle, for example. And for without any topographical concern, it was 1 centimeter in 1992 by Caddy, 2 millimeters by the Makuchi team in 2000, and now it's 1 millimeter. There is a very recent, impressive series, British series, of 2,700 patients saying that 1 millimeter is now the new gold standard. But of course, if, like the MD Anderson is presenting the things, if you say that R1 resection give worse result than R0 resection, it's an evidence for me, because it's a completely different problem if you are obliged to do it by necessity or if it's just a possibility. How to overcome the operability limits, how to spare more healthy parenchyma. I think we have to go to a de-escalation strategy regarding the normal parenchyma. But of course, we can go to an escalation strategy to kill more metastases. And these different strategies are not paradoxal. We can go in for the 2 strategies during with the same manner. So, if we want to spare more healthy parenchyma, we have first to decrease chemotoxicity. MDT decision, the surgery must be decided by the surgeon as soon as possible. If only 4 cycles are enough, go to surgery and do not wait for 6. It's an evidence. In liver surgery, we have a fantastic tool, which is the portal atrophy hypertrophy. I think there is no equivalence in surgical oncology to be able to play with the plasticity of the organ. So it's very interesting, fantastic for us to get an atrophy of the worst part of the liver and to get an hypertrophy of the healthy part. Sorry. It doesn't go back. I'm sorry, but I would like to go back, and it doesn't go back. Can you go back, please, the slides? Sorry. Because there is an important slide on the two-stage. Okay. Sorry for this inconvenience. It's immediately go to the. Okay, so just to say that there is the two-stage strategy, which is also fantastic because it allows to operate more patients. Go to the next step, which is intraoperative ablation, which is, for me, a revolution in liver surgery. With Human Fong from the Memorial, we have branded this new concept as a CARE concept, which means combined ablation and resection. As you know, ablation is a non-anatomic tumor destruction, not to compete, but to complete resection. It was introduced by Steve Curley and Dominic Elias in 2000, and after that, there was an ostracism, complete ostracism, due to the fight between the MD Anderson and the radiologist who wanted to take the market of the liver mets. And so it was quite impossible to speak from ablation in the Congress during 10 years. But at the end of this decade, some series from Adam, from Steve Curley also, say that, 21% of patients have ablation during the surgery. And finally, we have to wait to 2012, where the two prospective phase 2 dedicated to ablation, one by Theo Ruers from the Clock Trial and one from France, were published with very nice results. Local recurrence rate less than 6%, median PFS 16 months, and 5-year OS 43%. So it was necessary to validate on a larger scale what intraoperative ablation could bring. And it was decided to join 4 prospective databases, one from the Memorial, New York, one from Liverpool, Graham Preston, one from Aarhus, Denmark, and one from my center in Bordeaux. We joined 288 patients with 8% of extrahepatic disease, very important. Of course, 100% of CARE resection plus ablation, some radiofrequency or microwave, I think it's not very important. And you see the mortality is 1%. So we are not accepting the 10% of some series. PVO, portal vein obliteration, only 10%, which means that most of the time we pass through one stage. Very important for the morbidity and the toxicity. And the 5-year PFS was 13%, and the 5-year OS 37%. If you compare a series of advanced disease, look at the rate of extrahepatic disease. If you have no extrahepatic disease, you have 10% more of survival, both for PFS and OS. If you take the series of René Adam, which integrated some extrahepatic disease, we have the same survival. So there were 2 major data in this series. The first is that extrahepatic disease cut by 2 the survival at 3 years. So it's possible, of course, to operate extrahepatic disease, but it is a very worse prognostic factors. And I confirm what Jill told you, that when you have a complication, you divide by 2 the overall survival, which was for me a shock because I was not aware of such an impact of the complication, and we could perhaps discuss which is the biology behind this to explain such difference of results. How to kill more metastases? Escalating the pre-op medical strategy. I think we have to be confident with the medical oncologists to try more aggressive regimen like triplet plus beva, Cetux, and so on. And also, the intra-arterial route, I think, is very important. Very impressive result of conversion have been observed with such approach. How to treat invaded vessels? It's a main problem for the surgeon and the major pattern of unresectability. For portal pedicle, I'm sorry, I have no solution. We have just the possibility to make a R1 surgery. But for hepatic veins, we have a fantastic tool, which is intraoperative ablation under vascular exclusion. Because all the series of reconstruction, grafting, and so on give bad results and are very difficult to realize. Just remember this patient, this female patient, she had a very small 1 centimeter liver mets on the right hepatic vein, impossibility to make a right hepatectomy, intraoperative ablation under vascular exclusion, and this lady has now 3 years of follow-up without any destruction of healthy parenchyma. Another case, very interesting, this patient had a complete invasion of the right portal pedicle, and she has a liver met just in between the median and the left hepatic vein. This is unresectable. Or you have to resect this vein and to make a grafting technique very, very complicated. And we did a right hepatectomy plus an intraoperative ablation, and you see that the patient was fit after surgery. And the vein were not, there was no thrombus of the vein. How to manage very big metastases? There are some tricks, technical tricks, described, for example, by Jacques Belghiti, the hanging maneuver, which allowed to suspend the liver, to cut the bridge of the parenchyma before to mobilize the metastases, which often is sticking to the diaphragm. Killing more metastases by doing radical extensive hepatectomies. It was, remember the series of Belghiti, the Beaujon series. By necessity, of course, if you have to remove a big burden of liver mets, I do sometimes right hepatectomy extended to the fore. But on a prophylactic basis, the answer is now very clear. Never do an extensive hepatectomy on a prophylactic basis. You have more than 10% of mortality and very bad results. And Jacques Belghiti was very clear to say that we have to stop this with this strategy. We have not enough time to see some, I would say, clinical research niche, like ex vivo surgery, isolated liver perfusion, or liver transplant, which have been proposed. But if you have some questions, we could discuss later. Increasing surgeon skill. I think that one of the major factors that, which make that ablation was hard to break in the OP room was that a lot of HPB surgeons are not skilled in using intraoperative ultrasounds. Some surgeons are calling radiologists to position the needle into the liver mets to make a radiofrequency ablation. I think it is not acceptable. If you are a liver surgeon, ultrasounds are your eyes, and you have to be very skilled in manipulating the probe. So I think there is advanced courses like the ESO course I organized in Bordeaux to teach intraoperative ultrasounds. There is another one by Guido Torzilli in Milano. For which patient benefit are we doing all this tough job? Increasing overall survival. The more you will push the limits, the less you will obtain overall survival difference between the chemo only, and the Krug trial has demonstrated this problem. But probably we increase the PFS, and it was demonstrated by the two prospective series. And in my study, we also studied prospectively the quality of life, and we were just able to see that when the patient is in remission, the quality of life is better. It was demonstrated clearly. And so, in this setting, we can say that PFS is a better surrogate marker of quality of life than from overall survival. So I think if we can demonstrate that such a complex strategy, surgical strategy is useful, it may be just by increasing the quality of life through the PFS increment. As a conclusion and a take-home message, I would like to say that liver is a capital. As a surgeon, we have to manage it in a very conservative way. it's very important to have a de-escalation strategy of the healthy parenchyma. But of course, we collaborate with medical oncologists to increase the efficacy of the medical approach, which should be an escalation in the conversion therapies. I think there is a clear dialectical evolution, I could say, Hegel, in surgery between what we observe. First, it was anatomical resection brought by the liver transplant surgeon. It moved to non-anatomical resection. That's a slide was skipped during the presentation, I'm sorry. After we got the two-stage, the two-stage strategy, which is fantastic also because it allows to operate on more patients. And now we have the care, which is a very advanced concept, which allows to spare the healthy parenchyma and to operate a lot of patients. So sorry for the technical problems, and I hope that we will continue to work on a multidisciplinary basis. Thank you so much.